Good afternoon, everybody. My name is Sonia Ketzier, and I am one of the critical care pharmacists here at the University of Colorado. Today, my presentation is going to be on the pharmacology of antiarrhythmics. And I just want to preface this that arrhythmias is a large and very dense topic, and there's many things that we could talk about when it comes to arrhythmias. And so I really kind of want our group here to take a different approach, and I want us to really kind of put on our PhD hats and focus in on more of like a cellular level of what is truly going on when someone is experiencing an arrhythmia and how the medications we use can help circumvent the mechanism that's occurring. I am expecting that everyone has a basic understanding of ACLS algorithms, as I'm not really going to go through how to approach an AFib situation or a VFib situation. I'm really going to focus in on as to how these drugs are working in the setting of arrhythmias. So let's get started. And I want to begin with a quote that I really think sets the stage of what this topic is going to really focus in on. And this quote reads, "To fully understand the mechanism of action of antiarrhythmic drugs, one must understand both the underlying cause of the arrhythmia and the molecular target of the antiarrhythmic." So we're really going to focus in on how arrhythmias are generated and then how we can use these drugs, basically hitting ion channels and receptors to help stop this arrhythmia. And as I mentioned, that arrhythmias is quite a dense topic. And I really just basically have three objectives that I want everyone to walk away with by the end of this lecture. And it's to understand three terms: automaticity, conduction velocity, and refractory period. And these terms really kind of correlate to two different types of action potentials that we have. So the first one right here is the action potential of our pacemaker cells. So imagine like our SA node shooting off. And this term automaticity here refers to this phase 4 slope. And it really means just what is the speed as to which we reach the threshold in order to depolarize. And then this action potential here represents our cardiac myocyte. And this section right here, this phase 0, is called conduction velocity, basically referring to how quickly the energy flows through your cardiac myocytes. And then the refractory period is actually how long that action potential is lasting. But let's review some basics so everyone is on the same page going into this topic. We all should be familiar with how the heart obviously moves blood. Right atrium down to the right ventricle, to our pulmonary system, gets oxygenated, returns back to the left atrium, goes down the left ventricle, and then exits through our aorta to go to our systemic vasculature. That's great in how blood moves, but how does it actually move into these different segments of the heart? And that's what really comes down to electrical conduction. Our SA node is our pacemaker. It really sets the speed as to how quickly our heart is beating. So from the SA node, we send our impulse to our atria, and then it gets to the AV node. And at the AV node, it specifically slows down. And this is a key thing to understand because you need time for your atria to empty in order for your ventricles to fill. So it's a protective mechanism in itself to help facilitate that process. Once it gets to the AV node, it goes down the bundle of His, extends out into our bundle branches, and then into our little Purkinje fibers. And when that happens, then our ventricles contract. I'm not going to go much into EKG waveforms and understanding how to interpret an EKG strip. I think that could take a lecture within itself. I really want everyone just to have an understanding of what PQRST is. So P, of course, is our atrial depolarization, meaning the contraction of the atria. Our QRS complex is obviously quite more significant in its stature based on how much ventricular mass that we have. And that's the QRS complex. That's going to be your ventricular depolarization. And then their T wave is our ventricular repolarization. We're getting back to this nice resting phase, so then we can shoot off another action potential. Let's go into these action potentials. So as I mentioned to you in the very beginning, when we talked about objectives, I said that there's two different types of action potentials. One being the cells of our SA node, and these are called autorhythmic cells. And you can tell that they have a really distinct action potential and kind of looking like fin-like. And then we have action potentials that exist in, say, like our atrial muscles. And this is called contractile cells. And you can see that they look a bit different compared to the autorhythmic cells. And let's kind of dive into this a little bit more. So our contractile muscle cells have 4 different phases. We all sit at a negative 90 millivolts. That's just inherent to our cardiac myocytes. It's based off the Nernst equation where we find an equilibrium between our ion channels. Phase 0 is explicitly meaning quick depolarization. We have a little bit of repol at phase 1, and then we get to this plateau phase. And we're going to talk about the different ion channels that create these waveforms. Phase 3 refers to repolarization, and then we get back to our resting membrane potential at negative 90 millivolts. It's super important to understand that we sit at a negative 90 millivolts. We are not moving slowly at that negative 90 because our SA node is going to fire off. And when it reaches our contractile cells, when it reaches the atria per se, that's when it tells us to depolarize quickly. This is different from our pacemaker cells, which don't have like a necessarily resting membrane. They sit at their lowest threshold at negative 60 millivolts. And then once they hit negative 40, they depolarize. This is because our SA node always has to have some sort of movement in order for our heart to keep beating in a continuous manner. But once it depolarizes and it reaches the top of the action potential, you can quickly realize that there is no plateau phase. Your action potential then repolarizes right away, and then it starts its movement all over again. And then to understand action potentials, we have to understand where our cations are located. So potassium is obviously our most intracellular cation. It sits in the cytosol. And then sodium and calcium are typically in our extracellular fluid. So when we have a cardiac myocyte shooting off its action potential and it goes through phase 0 depolarization, what happens here is our rapid voltage gated sodium channels open. We have a rush of sodium ions that come into the cell. So positive coming in obviously raises us from negative 90 to say positive 20. Then we have a little bit of this repolarization here because we have potassium ions leaving. And when potassium's leaving, it's positive, so it's leaving the cell. So we have a little bit of bringing us down to like that 0. And then all of a sudden we have these calcium channels that start opening up, and they're kind of slow in opening. So that's why we didn't see them right away. And when they open, we have calcium coming in, positive coming in, and potassium leaving. Potassium is positive. So that's why you get this basically current that's opposing each other. So that's why you get this plateau phase. And then phase 3 is basically referring to the efflux of potassium still occurring. Those calcium channels have now closed, and we're trying to get back to that resting membrane potential. There's obviously other channels involved in this process, sodium potassium ATPase, sodium calcium exchangers. But for the simplistic basics of understanding action potentials, these are the main ion channels that you should have familiarity with. And then another important concept is to understand refractory periods. So right here, the ARP is called the absolute refractory period. And what this means is that during this phase, you are not allowed to shoot off another action potential. Why? Because you just don't have enough sodium to shoot off and have that energy efflux. And it happens during phase 0 and 3, but you can recognize that I didn't put the arrow all the way to phase 3. The reason being there's this relative refractory period. And what that means is that if you just have enough stimulus, just the right amount, you could potentially shoot off another action potential before you've completely repolarized. So we're going to use drugs that can try and help us extend this effective refractory period, this whole entire part that it kind of refers to the duration of the action potential, to help mitigate the potential for arrhythmias to happen during this relative refractory period. And then let's talk about the action potential of our pacemaker cells. So as I mentioned, we sit at a negative 60 millivolts as the lowest point that we'll go to. And we might all remember from pharmacy school at some point or other, these funny channels. And what the funny channels are referring to is you have just some slow sodium leakage, meaning you're never going to sit always at negative 60. You're always going to have movement. All of a sudden, we have our calcium channels that start opening up. We have 2 different types, our transient and our long-lasting calcium channels. The long-lasting was what really brings us to say like this negative 40 millivolts for us to depolarize. We depolarize, and then right away, we start effluxing that potassium and we start repolarizing back to that negative 60. And then we start that process all over again. Remember, we don't sit at negative 60. We kind of just get there and then start moving again. So here's the picture representing the different ion channels that we talked about. So when we talk about sodium channels and blocking those, we're using class 1 agents. When we talk about calcium blockade, we're talking about class 2 and class 4s, and potassium would be class 3. So if I ask the group, which agents will slow down conduction velocity, what would you say? Yeah, class 1. Now, if I asked which agents will prolong the refractory period, what would you say? Class 3, exactly. And then if I asked which agents will slow automaticity, class 2 and class 4. Great. All right, now let's talk about some arrhythmias. When I'm talking about utilizing antiarrhythmics, I'm really referring to tachyarrhythmias. We obviously can have bradyarrhythmias, and we can use different agents, atropine, glycopyrrolate, to help stimulate our heart rate getting back up. But when we're using antiarrhythmics, it's in the setting of a tachyarrhythmia. So how you approach this is thinking about, all right, am I dealing with a narrow or wide complex QRS? Narrow meaning you have the regular EKG waveform, wide complex meaning that there's something going on here, referring to that ventricular depolarization. So when you're dealing with a wide complex, think about an example would be like ventricular tachycardia. There's something wrong with your ventricles depolarizing. If we go back to narrow, we think about the different type of rhythm that we're in, regular or irregular perhaps. So regular, you can kind of imagine that you're in a sinus tachycardia. You have a normal EKG waveform, but you're just shooting off too many stimuluses too quickly. Irregular could be an atrial fibrillation where your R to R interval is just not cohesive, and that would bring you an irregular rhythm. So basically, arrhythmias come down to some sort of abnormality with your rate or rhythm. And there's going to be some sort of problem with initiating an impulse or how that impulse then moves through your heart. Another way to look at this is impulse formation. There's a problem here, and it could be with automaticity. There's that word again. There's that objective that we're going to really hone in on today. Or triggered activity. You could have early after depolarizations or delayed after depolarizations. Or it could be with conduction. And this is where we focus in on re-entry mechanisms. Re-entry is the most common arrhythmia mechanism. And the most simplistic way to explain this is that your heart has depolarized, and shortly after it's repolarized again. It got re-excited, and there's a problem with that. So an example of this could be patients who have congenital cardiac disorders such as Wolff-Parkinson-White. And Wolff-Parkinson-White is an example of an AVRT, an atrioventricular reentrant tachycardia. So what happens in this circumstance, your SA node will fire off. Remember, when it gets to the AV node, it has a protective mechanism to slow the impulse down to let things empty and fill. However, in patients who have a Wolff-Parkinson-White accessory pathway, they basically have that electrical impulse from the SA node shooting down the side. And there's no AV nodal protection there. So now this shoots down, and it can cause a global re-entry, and it can go back through the AV node and circulate around. We could also have re-entry that's specific in just like our atrial tissues or in our ventricular. I'm going to go through this mechanism, and it's quite complex, so stick with me here. The first way to kind of understand this is, say this circle right here that I'm on with my cursor is the AV node. And in some of our AV nodal tissue, we have these two pathways that kind of circulate to get to a distal connection. There's two different pathways that kind of get through this. Your fast pathway has a slow or a long refractory period, and that's kind of explained by this long tail, this long blue tail that kind of lingers behind it. And then there's got to be another pathway that has slow conduction, but its refractory period is much shorter, as you can see. So when this impulse goes down, it goes through the fast and slow pathway. When it comes down the fast one, it's going to go through that distal end, but when it meets up with that slow pathway, now that they've hit, they extinguish. And that impulse is done. There's no more movement, okay? However, if we add in, say, like a premature atrial contraction, look what happens. Goes on the pathway, moves, extinguishes, but now there's nothing blocking that premature beat, and now that gets to circulate around and around and around. And this is a re-entry mechanism. I'm going to explain this a different way to try and get everyone to have a full, thorough understanding. So again, think about our AV node being the center right here, and say a patient experienced a myocardial infarction, and now they have this scar tissue here. When they develop this scar tissue, there's got to be some sort of unidirectional block, meaning that you can have movement going through it retrograde, but not anterograde. So there's got to be 3 criteria to have a reentry mechanism. You got to have 2 pathways, and one of them has to have slowed conduction, okay? And then there's got to be this unidirectional block. So if I had a normal reentry mechanism occur, and this is what's happening, you're going down, it's shooting down the fast pathway, but it didn't go down the slow one because it met this unidirectional block, and it said, I'm not allowed to go down this way. So now this impulse propagates up this way, and then it goes through this tissue because it's allowing for this way of unidirectional block. This dotted tail right here is referring to that refractory period. And because this beginning of the action potential hasn't hit that refractory period, that tail, it's able to keep circulating and circulating and circulating. So how do we actually stop this? Well, we can use drugs that can help us slow down the conduction or the automaticity of the action potential. And specifically, we can use class 1 agents as our sodium channel blockers, and they're going to slow down conduction velocity. Again, they're going to take that phase 0 depolarization and slow it down. Or we can use beta blockers and calcium channel blockers and think about that automaticity at our pacemaker cells, and they're going to slow down that phase 4 depolarization to get to that threshold. So what's going to happen in this circumstance, say, same pathway, it hits the slow pathway, but then unidirectional block can't move down that way. So it starts moving down and propagating down the AV node. And you can see it's much slower than what I was showing on this side. It loops back around. And because we've slowed things down so immensely, it basically hit its own tail and extinguishes. That's the end of that action potential. No reentry mechanism has occurred. Or what we can do is just prolong that effective refractory period. And then the same idea, we're going to use sodium channel blockers, specifically class 1As, and potassium channel blockers. And what's going to happen in this circumstance, it's going to loop back up. There's that refractory period coming in. It's going to hit itself and extinguish. Then there's the concept of automaticity. Again, with tachyarrhythmias, we would have an increased automaticity. And think about this as your SA node is still like appropriately in charge of setting the rate, but it's just become too quickly. It's in some disorganized manner. Or we can think about some sort of ectopic focus, where you have another part of your heart that's taken over and is actually the new pacemaker. And we call that like a junctional tachycardia. There's so many reasons as to why this can occur. A few are just ischemia in general, electrolyte disturbances, hypoxia, and we can even think about drug toxicity such as digoxin. So what happens here is the blue outline is showing you a normal waveform of the action potential. In increased automaticity, you can see here, again, that phase 4 slope has like much increased. And now you have many more action potentials within that same waveform. So how do we block this? How do we kind of get back to a normal rhythm? Well, if we all sit at a negative 16 millivolts and then we shoot off and depolarize at negative 40, what if we just reduce that resting membrane potential to say like negative 90 millivolts? Well, in that circumstance, it's going to take a lot longer to get to that threshold, right? And then we're going to shoot off. So it's going to help us slow things down. We're going to do that with beta blockers and calcium channel blockers primarily. Our class 1A agents, or class 1s in general, can do this as well. Because remember I mentioned too that there's like those slow, funny channels, that slow sodium leakage. Again, they can work there, but they're really more focused on like an ectopic area. Like you say, like your Purkinje fibers have now become the pacemaker cell. That's where these class 1 agents can really become more effective. And again, that's funny channel is not voltage gated sodium channel. So that's why this is kind of different, but they do help still prohibit some sodium movement. Another way of doing this is that we can just increase the threshold potential so that we shoot off at a negative 20 millivolts. And then if we just wanted to slow down the slope, we could do that with these agents. And that helps us decrease automaticity. And then there's triggered activity. Triggered activity is basically you have an after depolarization after your impulse. And there could be early after depolarization. This occurs either during phase 2 or phase 3. So remember, phase 2 was really focused on calcium channels, and phase 3 was potassium. So in this circumstance, maybe we just had too much calcium coming in, or we don't have enough potassium to bring us down to that resting membrane. There's many reasons as to why this happens as well: medications, lights, electrolytes, hypoxia, acidosis. And basically what's happening here is that you have a prolonged QT interval. And this is what the risk obviously is concerning for torsades. So you have early after depolarizations here. Again, you see that QT interval now being prolonged, and that's what's going to get you that torsades picture. What you do to treat the situation is, of course, just address the prolonged QT, fix the underlying cause, whether it's medications, a septic state, whatever it may be. There's also delayed after depolarizations. And this basically comes down to some sort of issue with calcium. So you've just had a little bit of calcium influx. You have too much intracellular calcium occurring. A great example of this is, say, like digoxin toxicity, where you have too much calcium being released from your sarcoplasmic reticulum. And how we could really think about fixing this is obviously addressing how much intracellular calcium that we have, and that's class 2 and class 4 agents. We can also think about sodium calcium exchangers. So if we use sodium channel blockers, we can also help prevent that pump. And then, of course, if the underlying problem is digoxin toxicity, we would address that. So I'm going to ask a couple of questions just to make sure that everyone's on the same page with these mechanisms, because I know they can be quite overwhelming. So prolonging the effective refractory period will prevent reentry. Right here. Good. True. Beta blockers and calcium channel blockers can slow down automaticity. True. A prolonged QT interval can lead to early after depolarizations. True. The important thing to understand here, though, is that even though we can use drugs that can prolong that effective refractory period to help basically distinguish that reentry mechanism, as I showed you a couple slides ago, but this is why they could lead to early after depolarizations. This is why these agents are considered pro-arrhythmic, because even though they stop one mechanism, they can originate another one. And then the last question is, beta blockers and calcium channel blockers can suppress delayed after depolarizations. And remember, this is a calcium problem here. You have too much intracellular calcium. True. Great. Okay, so now we get into the antiarrhythmics, and this is the fun stuff. Basically, what we're doing with antiarrhythmics is we got to change that action potential. There's been an arrhythmia, there's some sort of distortion with how that shape of the action potential is, and we're going to fix that by targeting different ion channels. And von Williams classification is the oldest way that we've looked at antiarrhythmics. It's highly imperfect in how things are categorized within the system, but it's the most well adopted, I guess, at this point in time. So it gets broken down into class 4, 1 through 4, and class 1 specifically gets broken down into class 1A, 1B, 1C, and it's based on different effects that we'll get into. So von Williams class 1, and these are some examples: quinidine, lidocaine, and flecainide. They're all going to be working on sodium channels, and that's why they're categorized as class 1s as their primary mechanism. And so when they work on those sodium channels, they're going to slow down conduction velocity, but each of them to a different degree. And then some of them may have an effect on the refractory period. And because they hit some sodium ions, they're going to suppress some automaticity. All of them work for atrial or ventricular arrhythmias, with the exception of class 1Bs, lidocaine and mexiletine, and we'll explain why that happens. Class 2 is our beta blockers, and really how they're going to be working is indirectly blocking calcium. They're going to decrease conduction velocity, extend the refractory period in our AV node, and then as a primary mechanism, decrease automaticity. Class 3s, this is a really broad class. Think about these as just being pure potassium channel blockers. So what they're really doing is extending out that refractory period. And class 4s are non-DHP calcium channel blockers. These, of course, are going to be blocking calcium directly, and they're going to have the same outcomes that beta blockers do. All right, so class 1s. When you really need them, you really need to know them. And honestly, in clinical practice, you may not come across these quite often unless you're specifically working in a cardiac or cardiothoracic ICU. However, I think it's good to have an understanding of what things you should be looking out for with these agents and how they actually work. In order to understand that, we need to start with voltage-gated sodium channels. And so class 1 agents only bind during the open or inactivated phases of the action potential. During the diastole or resting phase, they pop off the receptor. So their kinetics are very state dependent, and how they come off the receptor depends on their dissociation kinetics. So class 1As have intermediate dissociation, class 1Bs have fast, and class 1Cs are slow. So imagine that a class 1B agent like lidocaine binds, and it typically binds at the inactivated channel. Once the diastole happens, it's quick off, and it can jump onto the next action potential and try and block it. Whereas class 1Cs have slow dissociation kinetics. So even though that diastole happens and the drug has come off the receptor, it still hasn't come completely off. So there still is some residual sodium channel blockade that exists during that diastole, that resting phase. And another way to kind of look at this is, here's your voltage-gated sodium channel, and there's two different types of gates. You have an activation gate and an inactivation gate, or they're also referred to as your M and H gates in the literature. So when you're in your resting phase, your activation gate is closed. You're not allowing sodium to come within the cell. However, when you open, again, you have that huge, quick influx of sodium, boom. There your inactivation gate closes, and that's representing your phase 0 depolarization. So let's talk about what happens if we had a class 1 agent. So if we do that, you can see that this inactivation gate kind of closed, and the channel actually became a little bit narrower. So now when it opens and we try and get sodium to come out, it's much slower. And that's what results in this phase 0 depolarization being slightly prolonged. So quinidine, procanamide, and disopyramide make up our class 1As. Really, they have those intermediate dissociation kinetics, so their effect on conduction velocity is pretty good. They are also specific for refractory period extension. So this is how their new action potential would exactly look like. And again, when you prolong that refractory period, you're putting the patient at risk of early after depolarizations. This is why class 1A agents are considered pro-arrhythmic. And again, because they have some sodium blockade, they are going to suppress some automaticity to some degree. Procanamide, quinidine, disopyramide are universally available to use for atrial or ventricular arrhythmias. And I want to talk about procanamide specifically. So procanamide has an active metabolite, N-acetylprocanamide, or NAPA, and it makes up about 25% of the active drug. And interestingly enough, procanamide, when it gets converted to NAPA, NAPA has no sodium channel blockade. It's a pure potassium channel blocker. So now you have two agents on board, and it's super important that if you do initiate or continue someone on this therapy, that you are getting procanamide and NAPA levels separately to ensure that they are not getting to toxic levels. And I know we perhaps don't see procanamide as often, but it's actually quite effective. And this is reflected in the ProCameo 2016 study. This was a randomized controlled trial where they looked at 70 such patients with a wide complex tachycardia. And they compared procanamide 10 mg per kg versus amiodarone about 5 mg per kg. And they did 20-minute infusion. And the primary outcome that they were looking at was MACE, so your major adverse cardiovascular effects. And you can see the quite significant reduction in the procanamide group compared to amiodarone. They said, great, all right, well, it reduces cardiovascular effects, but that tachycardia that we were dealing with, well, how quickly was it resolved? And so they measured how quickly that resolution came 20 minutes after that 20-minute infusion, so 40 minutes after initiation. And you saw that 67% in the procanamide group versus 38%. And that was a statistically significant finding. This is great. It shows that procanamide has good efficacy. But at the end of the day, what this trial really showed is that if you do have someone in a wide complex tachycardia, like a VTAC, VTIB, you're most likely going to be cardioverting them. And that's what the study really showed. And to be quite honest, when you look at international guidelines, like Canadian guidelines, you do see the use and recommendation to use procainamide earlier on than amiodarone, perhaps. I'm not sure why it just hasn't been adopted into the US. Maybe there's just like a availability issue with it. But if you do come across it, I think it is important to know that procainamide does have good evidence behind it for its use. Class 1B agents. So this includes lidocaine and mexiletine. The important thing to know about these agents is that they really only bind during the inactivated phase right here, not so much the open part. And that's going to be super important when we talk about other issues with these drugs or maybe benefits perhaps. So because it has really quick dissociation kinetics, its effect on conduction velocity is quite minuscule. And it really doesn't have an effect on the refractory period. Theoretically, it's been shown to reduce it. Whether that's clinically relevant, I don't think so. And I don't think these agents should be used in the setting of trying to reduce someone's QT interval. But theoretically, if they do that, they're going to suppress any kind of depolarizations. And then as a sodium channel blocker, again, they're going to have some automaticity suppression. What you should recognize quickly is that I have dashes here for atrial arrhythmias and that these agents are only specific for ventricular. And the reason being is because our atrial action potentials are actually much shorter than our ventricular action potential. So you can see that here versus here. And so when I told you that lidocaine, we'll talk about lidocaine as being class 1B, specifically binds to the inactivated phase, you can see how short that phase is here in the atrial tissue compared to the ventricular. So the action potential is not long enough in atrial tissues for class 1Bs to really have its effect. Because class 1As and class 1Cs bind during the open phase right here, they don't care about how long that action potential is. They've already bound, they're good. But it's just where lidocaine's binding. So that's why it's really not effective for these atrial arrhythmias. Another thing that's important to understand with lidocaine is about lidocaine toxicity. And specifically, you're going to think about two systems, neuro and cardiovascular. So patients will typically present with some sort of neurological symptoms, including like dizziness, leading to like hallucinations, delirium and such, seizures in the worst kind of cases. And then they'll potentially start developing some cardiovascular toxicity. And the main thing that you're concerned about here is like hemodynamic collapse. And interestingly enough, we did have a patient who in our cardiac ICU was admitted with a super therapeutic level of 12, where our reference range is about like 1 to 6, and they were symptomatic. And so what you do in that circumstance, the antidote to a lidocaine toxicity is an IV lipid emulsion. And so lidocaine is a highly lipophilic, like local anesthetic. And as a lipid emulsion, you would essentially bind to that highly lipophilic molecule, pull it out of the offending areas, like your heart and your brain, creates this complex, and it basically sends it to the liver and the muscle to get metabolized and excreted. And then another question that you may come across is, why is lidocaine better in ischemic tissue? So specifically, say if you have a patient who had a myocardial infarction, why is it better to use lidocaine in that patient versus someone who doesn't have any ischemic disease? The reason why is we talked about action potentials of our cardiac myocytes sitting at a negative 90 millivolts, right? And you can see with the graph below it, what's representing here on the x-axis is percent of channels blocked. And then time would be on your, your x-axis is time, your y-axis is percent channels blocked. So you can see here that when you shoot up this action potential, this is a 50% mark, and you have a fair amount above that 50% mark when you have the action potential shoot off. However, in the setting of ischemia, your cells actually become more depolarized. So instead of sitting at a negative 90 millivolts, now you sit at a negative 60 millivolts. And what that translates into is you can see now how many channels of sodium are being blocked. You basically have more sodium or more lidocaine staying on the channel because it's more depolarized, and you're going to get that significant sodium channel blockade. You can think about this as in normal tissue, lidocaine jumps on and jumps off, fast on, fast off. In ischemic tissue, it's fast on and slow off. So you get that residual sodium channel blockade even when it's popped off. And then the last class 1 agents are flecainide, propafenone, and morsazine. So these ones have really slow dissociation kinetics. So they're going to stay on that receptor for quite some time. And that's what really correlates to that really reduction in your significant reduction in your conduction velocity. They have no effect on refractory periods, and that means that they don't have early after depolarizations. That doesn't mean that these agents are not proarrhythmic. They are probably, I would say, the most proarrhythmic in this class 1 group. However, they just cause different mechanisms as to how they relate to proarrhythmias. And again, as a sodium channel, it has some degree of automaticity reduction. It can be used for atrial or ventricular arrhythmias, but I highly caution the use of these agents. And this is really based on the CAST trials that were done. So they looked at patients who were post myocardial infarction, who had some sort of ventricular ectopy. And they looked at class 1C agents, including enconide, flecainide, or morsazine. And they wanted to look at the reduction in mortality. Theoretically, it seems like these agents would be beneficial in this group. It's not until clinical evidence comes out and we actually see what it does to patients that we get more of a clinical insight as to how harmful or beneficial are these drugs. And what we saw in the first CAST 1 trial, where they looked at flecainide or enconide versus placebo, enconide is no longer available. They saw that there was a significantly increased mortality in both groups using the class 1C agents, and a mortality about 2 to 3 times. That's quite staggering. And then this was confirmed in the CAST 2 trial, which showed that morsazine, which is also class 1C, it's no longer available, also had an increased risk of mortality. The take-home message is really, do not use these agents in the setting of ischemic heart disease, patients with heart failure with a reduced ejection fraction, or severe left ventricular hypertrophy. And just to summarize all the class 1 agents, because I know this is quite a lot, really think about procainamide being effective for atrial and ventricular arrhythmias. I personally, from my practice, I extend the CAST trial results from the class 1C group all the way to the class 1As, because it is still a similar mechanism in sodium channel blockade. And I just caution the use of patients with ischemic heart disease, HFrEF for left ventricular hypertrophy. And I get, it's a team discussion at that point about whether these agents are safe or not. Really in practice right now at this point, procainamide I think falls into like a second or third line drug of choice after amiodarone and lidocaine if you have a patient with sustained ventricular arrhythmias. Lidocaine is really kind of put into place as a second drug of choice after amiodarone, specifically to terminate ventricular tachycardias or prevent another VFib situation after direct cardioversion. Again, only specific for ventricular arrhythmias. And then flecainide and propafenone, really think about these in the setting of like a refractory SVT situation. And again, do not use them in patients who have ischemic heart disease. And then we go on to the class 2s, and these include beta blockers. And what I'm trying to do with this image here is I'm really trying to explicitly show you how much your heart is innervated. So your SA node and your AV node, and you have a lot of sympathetic innervation there and a lot of parasympathetic innervation there, so your vagus nerve. And what beta blockers doing are obviously trying to block catecholamines from binding to the receptors to stimulate this process. So what it's essentially doing is, okay, so here's your catecholamines, beta 1 and beta 2 receptors. They're going to block the attachment here. And you can see the downstream effects of ATP and such and calcium contraction that we're trying to basically inhibit. So it's a calcium channel blocker, but indirectly. Class 2s have some or maybe no effect on conduction velocity, but what they really do is they extend out the refractory period in the AV node specifically. And again, when you extend out that refractory period, you're going to help decrease the mechanism of re-entry. And then automaticity, of course, because they're slowing down this phase 4 right here, that's what's going to decrease automaticity and decrease heart rate. Specifically, they're going to be used for your atrial arrhythmias because they're working mainly at the AV node. They can help in some circumstances for a ventricular arrhythmia, just in the setting of decreasing that ventricular response to those tissues, but really think about them as like your supraventricular agents. Class 3s. These make up like sotalol, ibutilide, and dofetilide, and we'll talk about amiodarone in a second. These agents really have no effect on conduction velocity. Their primary point of action is that potassium channel blockade and extending out that refractory period. Again, what happens when you hit that refractory period? There comes that early after depolarization risk, right? And they have some degree of suppressing automaticity. I don't think the mechanism has been truly determined at this point, but just recognize that there is some effect there. Sotalol does have class 2 effects, so it does have beta blocking effects as a LOL. So that really kind of allows it to be available for atrial and ventricular arrhythmias versus ibutylide, which is specifically for like an AFib, a flutter situation. I caution the use of this agent just in the setting of having decreased efficacy. Maybe 50% of the time you can cardiovert someone, but the risk of QT prolongation is quite significant. And then difetilide, specifically used for like AFib and aflutter, there are some situations and some data to support it in the ventricular arrhythmia mechanism. And then amiodarone. So amiodarone, I would say, is my favorite drug. And the reason being, I think it's just so promiscuous. It does everything. It does it all. And so it has class 2, class 3, and class 4 effects. So it's going to decrease conduction velocity to some degree. It's going to extend out that refractory period. Again, when it does that, you put a patient at risk of early after depolarizations. And with its class 2 and class 4 effects, it's really blocking that phase 4 depolarization, so slowing down automaticity. Again, look at all the pluses here that I've tried to illustrate for how effective amiodarone is in many types of arrhythmias. What you need to understand about arrhythmia is that it's quite complex. And I think this is great teaching points for your medical team and such, nurses and whoever, about how amiodarone is actually working. So when we give an amio bolus, say we give someone 150 milligrams of amiodarone, what we're really doing is just saturating the central compartment, so our body's serum. And within 24 hours, we've kind of saturated that area. That's really where you're getting your class 2 and class 4 effects. You're suppressing that automaticity. Your rate control is what you're doing with amiodarone in that first 24 hours. Then it's going to start distributing into your different compartments. So your peripheral compartment starts saturating your body's tissues and organs. And that takes about a week to do that. It's not until weeks to months that you start saturating this deep compartment. And this deep compartment is really like, think about your fatty organs, your lung, your liver. When you recognize the toxicities with amiodarone, that's where these toxicities start to develop after weeks to months of saturation of those areas. The important thing to take home about amiodarone is that when you are giving someone amio acutely, say in the ICU, that QT interval is not there. That extension of it is not there because you haven't really gone to that class 3 effects. You haven't saturated that compartment. What you've done is if you've prolonged that refractory period in your AV node, you've saturated this central compartment and you're getting rate control. Your repolarization in your atrial ventricular tissues has not been affected yet. However, once you've loaded someone and they're now on a regimen, that's where you start thinking about chronic use of amiodarone and that extension of the QT interval and the repolarization in all your different types of tissues. This kind of constitutes what do you get worried about when you use amiodarone. I'm not going to go through all the different toxicities, but the main systems that you should think about are obviously cardiac, neuro, GI, thyroid, pulm, and hepatic. And to kind of rest assurance to amiodarone, there really is no contraindications for utilizing it. There are situations where I caution and I like take a step back and think about, is this the appropriate agent? Specifically, am I thinking about putting someone on this for chronic treatment? And do they already have a baseline prolonged QT? Or how long have they been in AFib for? And do they potentially have like a known atrial appendage thrombus? And then if I cardiovert them, and now am I going to now have more poor sequelae down the road? And then I also think about 2nd or 3rd degree heart block and just how much AV nodal blockade I'm going to get. And am I going to throw them now into like a cardiac arrest? Also think about the drug interactions that you have with amiodarone, specifically digoxin and warfarin. So the take-home points really with amiodarone is it has a very slow onset, very slow elimination. Do not be afraid of using amiodarone in the acute setting. It's not going to give you that QT prolongation. It's okay to use as long as you consider the different cautionary statements I went through to give amiodarone. And then the last group is our class 4s, and these are non-DHP calcium channel blockers. And really what they're doing is just trying to slow down that AV nodal conduction. And specifically, this is for our non-DHPs like verapamil and diltiazem, because they're specific for our cardiac cells, versus our DHPs like amlodipine and nifedipine were specific for our like peripheral vasculature and helping to decrease blood pressure for hypertension. So again, similar mechanisms to beta blockers, conduction velocity may or may not be decreased. That AV nodal prolongation is really the main effect, and then suppressing that automaticity at phase 4. Again, working for your atrial type of arrhythmias. There's many different drugs that we can also talk about with arrhythmias, and I wanted to give them basically a shout out, but I for this time of this lecture, I didn't want to go into much details of these agents, but digoxin, adenosine, atropine, and magnesium sulfate, say in the setting of torsades, and why is it utilized? What's the mechanism behind it? I'm more than happy to talk about these agents offline. Just shoot me an email, but that's it. So thank you so much for joining this lecture. I know it's quite overwhelming to think about how these drugs are working and thinking about it maybe more so from a cellular level rather than just like a clinical approach and thinking about an algorithm that you have. I think it's interesting to provide as a pharmacist your understanding of what channels are being disrupted in the setting of an arrhythmia and how we can use these different agents to really kind of fix that underlying problem. And I'm happy to take any questions. Please shoot me an email if there's anything I can help clarify. Thank you so much, guys.